Ladies and gentlemen, now we'll begin with the next segment of this session too, and that is the expert session. Ask the experts, new paradigms in financing healthcare, putting patient and quality at the top. Now, the moderator for this session is Mr. Harish Natarajan, Director HxCo India. I'm going to introduce him, and thereafter he will introduce our panelists. Ladies and gentlemen, HxCo aims to establish dialogue with the government, insurance companies, and provider groups to drive alternate models in healthcare that move from the conventional cure-oriented models to more holistic community-based approaches that place importance on proactive healthcare and early intervention while delivering business objectives on every stint. Mr. Natarajan, Mr. Harish Natarajan has actually been at the forefront of several initiatives that aim at improving the quality of healthcare education and patient support in India. He helped incubate the Chronic Care Foundation, an NGO funded by Baxter as well. So a very warm welcome to you, sir. I'm going to ladies and gentlemen, just announce the names of the speaker: Dr. Abhay Soy, Chairman and MD, Max Healthcare Institute; Mr. Mayank Bathwal, CEO, Aditya Birla Health Insurance; Mr. Nachiket More, Visiting Scientist, the Banyan Academy of Leadership in Mental Health; and Ms. Sangita Patel, Director, Health Office, USAID India Mission. With that, I'm going to request Mr. Harish Natarajan, our moderator, to please initiate the discussion. Sir, please
Thank
take
you so
it
much.
away.
Thank you so much, Aishwarya, and congratulations to NatHealth again on all these wonderful partnerships, but also in terms of putting together such a wonderful program for the summit, right? And let me just talk about this session in for a minute now. The first panel discussion, it seeks to explore new frameworks for financing healthcare that will keep the patient's interest at the core and focus on driving quality at an affordable cost. I trust you've brought in your lunches, for I have 4 panelists who are certain to keep you glued to your screens for the next 35 minutes. This session seeks to explore and find answers to some very, very important questions. Some of the questions which we've been asked even in the morning, and there have been several thoughts about this expressed in the morning session, which is how do we build in the right motivations and incentives for providers to focus on outcomes and quality and not just episodic care? Is there a case for payer organizations to collaborate for buying synergies and better outcomes? How can government and private payers unite on this common mission? Recognizing that healthcare spends will be primarily out of pocket, while we are hoping that at some point of time the government will play a big part in it. But what are the innovative financing models that can move consumer mindsets from only funding catastrophic events to focusing on overall health and early intervention? So without further ado, I must sort of actually introduce the eminent panel. Let me start with Ms. Sangita Patel. Ms. Patel serves as the Health Office Director at USAID in India since 2019. Right, she's been with USAID for the last 2 decades and has worked on programs to promote health and education, strengthen health and social protection systems, further humanitarian assistance, and reach vulnerable populations. So prior to India, she served with USAID in Pakistan, Zambia, Armenia, Namibia, in addition to stints at the USAID headquarters in Washington, D.C. And she brings a rare blend of domain expertise and experience in translating concepts into the developing world. Lovely to have you in the session, Ms. Patel. Now, moving on to Dr. Nachiket More. Dr. Moore's current work is principally focused on the design of national and regional health systems. He's currently a visiting scientist at the Banyan Academy of Leadership and Mental Health and a senior research fellow at the Center for Information Technology and Public Policy at IIT Bangalore. He's also a member of the Health Insurance Advisory Committee of the IRDAI and a commissioner on the Lancet Commission on Reimagining Healthcare in India. Dr. More previously headed the Bill and Melinda Gates Foundation in India. He was a member of the Planning Commission's HLEG on universal healthcare. Lovely to have you here, Dr. More. Moving to Abhay Soy. Abhay is the promoter, chairman, and managing director of Max Healthcare Institute Limited, an entity formed with the merger of Radiant Life Care Private Limited and Max Healthcare in June 2020. MHIL is now the second largest hospital company in India, with a revenue in excess of rupees 4,000 crores, with over 3,400 beds across 16 locations. Radiant has been the fastest growing hospital chain in India over the last decade. Starting in 2010 with 10 employees, the group today employs over 24,000 people, including 2,600 doctors and 6,000 nurses. Great to have you here with us today, Abhay. Now, last but not the least, we have Mayank Bathwal. Mayank is the Chief Executive Officer at Aditya Birla Health Insurance, a joint venture between Aditya Birla Group and MMI Holdings of South Africa. Mayank set up Aditya Birla Health Insurance in 2015, and the company under his leadership has grown into one of the fastest growing health insurance companies in India. He's been quick to bring in innovation into the sector with differentiated business models that focus on keeping subscribers healthy and reducing catastrophic events. So which is quite a change from how it has been historically. So welcome aboard, Mayank. It is really a privilege to be addressing and moderating this panel. And let me start off with a question to Ms. Patel. Ms. Patel, I know that USAID has been at the forefront on healthcare financing and specifically brought in some very innovative schemes in financing. Can you please share some of your thoughts on the need for innovative financing in India and how USAID has contributed to the same in the recent past?
Thank you so much, and I really appreciate the question as well. I think that as we've all seen, basically prior to the COVID-19 pandemic, there already was an annual funding gap. It was highlighted earlier, especially to achieve the Sustainable Development Goals. We know that to be able to reach health and well-being, already it was estimated that we were at a gap of 371 billion for low and middle income countries. So already we knew that we have to somehow be able to merge our development needs as well as our commercial needs and really find innovative ways to leverage more. So at least with USAID, certainly we've seen that from our experience, whether it's results-based financing or even catalytic funding or impact investing, there's multiple tools that are out there, but we've certainly found that especially socially responsible investing remains underutilized. For us, we've also seen that at least, for the past 5 years, indeed, that less than 3% of the total development financing institution investments were really in the health sector. And most of the investments have been in infrastructure or pharmaceuticals. But impact investments directly to finance healthcare or ancillary services, human capital, or even things like medical devices, there's sorely a need. For us, at least, what we found in our experiences, even with the most recent Impact Investors Council report, in India in particular, overall investment, especially for health, has fallen due to this pandemic by over 70 cents since the beginning. So what we see here is a tremendous gap between the resources that are available and certainly the high priority evidence-based impact interventions that we know can improve care. What we found as well is that we really are at a turning point. Certainly with the Lancet in 2018 and their survey, the Lancet Quality Commission really proclaimed that quality has eclipsed even access as a driver for survival. So given these kind of variables and knowing that there is still that gap in reaching the SDGs, we feel that certainly value-based care is a compelling framework to be able to advance quality. So for us, financing, even from our experiences in innovative financing, is really an important lever to drive efficiency, improve quality, improve outcomes, and ultimately utilization of the services ultimately that we're trying to make available. Some of our experiences in India have shown, especially through some of the pioneering work, whether it's Utkrisht and the world's first development impact bond to really improve maternal newborn health outcomes. We've tried to at least show that we can link payments to accreditation, certification, and ultimately improving quality within private healthcare facilities. We've also worked with Mukti, which is a first ever pay-for-performance model, really be able to link payments to TB treatment. And then, of course, value-based care, specifically to be able to improve care for TB patients, linking to incentives and outcomes. But I think basically our work has shown that there's a need that value-based care models can help address some of that, 9 of the 16 million avoidable deaths per year. Now is really the time to act and be stewards to drive these kind of innovations.
Well, thank you so much for that, Dr. Patel. And now moving on to Dr. Moore. Dr. Moore, I believe that you have some slides which you want to share, and I know that you have a huge breadth of experience in both finance as well as in healthcare. So it'd be lovely to have you and look at your slides and see how we can learn from some of them.
Thank you very much for having me here. As was I was introduced, I work in what they call health systems design. It's somewhat of a fuzzy field, but what I look at is what do we do today with a view of 20 years later, 15 years later, so that we don't solve problems of right now, but we try and understand what the implications of these decisions would be as we move forward. And one of the questions that was put to me when we were discussing this earlier was, how does the whole financing issue for hospital care, tertiary care, get sorted out? I try to look at what the global evidence is telling us, what the Indian situation is, and where the directionally we might go. One reality, can you move to the next slide, of India that is, in a way it's not good, but in a way it offers an opportunity, is that the entire market is really quite, fragmented. It's about a 10, 11 lakh crore market, depending on how you count it. And I'm not even counting those people that forego care. The corporate sector, if I take all the large chains put together, is under 3 or 4% of that market. So really, it's an unusual, if I look at other sectors, I used to be a banker earlier, you don't see this kind of fragmentation in almost any other market. Insurance penetration is tiny. Indeed, government has some schemes, but they're also quite small because their overall money allocation is quite low. So we are at an early stage of evolution of our health system, and we are not doing well. If I look at this daily rate at the bottom of the screen, you'll see that we are somewhere at the bottom 50 to bottom 60 in terms of rank around the world. Even our neighbors, Bangladesh, which is a much poorer neighbor, is actually doing much better than us because it executes. It doesn't have a better health system necessarily, but it's executed the older ideas much better. And Sri Lanka is clearly, well above where even the best of our situation might be. And we have another statistic which is also bothersome, is that a very large proportion of households face impoverishment due to healthcare expenditure. If we are aspiring to be a country, COVID has set us back a little bit, that poverty rates will go below 1%. To add 8% every year and then have to work that back puts a drag on the weight on the poverty fight every single year. There is therefore an opportunity for us to examine what do we do from the very beginning. The one thought I would have, somewhat controversial, and me and Harish had a little bit of a discussion about it, is that pure indemnity insurance of the type that we are familiar with, which is separated out from the healthcare industry, hasn't really worked out well for many nations around the world. And in fact, we have Madam Patel here. US is a good example of how actually managed care started early in the US. But the Blues, the Blue Cross Blue Shield, were an indemnity insurance provider. And Medicare and Medicaid copied BCBS, didn't go the managed care route. And in a way, you see the reality, government of the US spends 8% of its GDP on health, but is not able to serve more than 40% of the population. It then has to depend on commercial insurance to serve the balance portion. Can we go on to the next slide? So the quick thought I want to leave here is that the current situation where both on the provider side and on the payer side is a problematic one. And I believe that the solution actually lies very much on the provider side, not on the payer side, at least as we currently understand it. The current situation we have has got a number of issues. I won't read this out. I'm happy to share the slides later on. But the reality is that the provider sector is growing at a tiny rate. I watched this sector for the last 25 years. There isn't a 100,000 crore provider in the market. The largest providers are at 5, 7, 8,000 crores. Profit bases of 200-300 crores. clearly this has to change. And financing is an important portion of it. But the thought, can you move on to the next slide? That I want to leave here is that bringing these two together into a framework that is both integrated vertically, primary, secondary, and tertiary, and integrated horizontally, is the way the world is going. The most fragmented market that we know of, which is the US, if you see all the major hospital chains today, Geisinger, Intermountain, Providence, they've all gone in this direction. And there is a very nice, in the New England Journal of Medicine this morning, there is a very nice interview of the CEO of Geisinger, who argues that by 2030, he expects all other forms of provision and financing to disappear. Already pure indemnity insurance in the US is 3% of the market. It's almost gone from the landscape from being 80% of the market maybe 20 years ago. So I'll stop here. You know that we have many more speakers to come. I just want to leave the thought here that any other mechanism, my fear is, leads to poor outcomes, both at an individual level as well as at the systemic level.
Thank you so much, Dr. Moore. I think like these are really thought-provoking questions. I wouldn't call them controversial because I think like many of us understand that this is the need of the hour at this point of time. The question is how and how we reach out to it, which kind of brings me to Abhay. Abhay is also the other person who's made this dramatic transformation or the dramatic transition from finance into healthcare, right? And as we've sort of seen through the introduction. Now, Abhay, while we keep talking about it and value-based care, etc., you have the best, I think, like practitioner view at this point of time. You know, I'm just talking about the seeming conflict between quality and patient centricity on the one hand and financial returns to the shareholders on the other. So obviously you need to sort of actually balance and make sure that you achieve both. Now, from your recent experiences, how do you address this issue in the running of your company?
So thank you, Harish, for having me on this panel. I think on the contrary, I believe both quality and patient centricity are prerequisites for sustainable profitability and sustainable growth. So it's not a conflict, but it is a necessity for it because, you know, as you're aware, we also, most of our hospitals are in metros where there is abundance of choice. And I think, you know, Nachiket also had sort of alluded in his presentation, you know, there is competition for doctors, and there is also multiple choices for quaternary care and tertiary care, particularly in the metro cities. There is a shortage in the rest of the country, but perhaps it's not the same here. And so therefore, patients have a choice. We live in a sort of one degree of separation sort of environment where word of mouth goes around. So you can't, what you can't do is cut corners on patient centricity and quality care. You know, that is clearly, like I said, something which leads to sustainable profits. In fact, one of the first things that we did, you know, after creating this platform, Max, Radiant, Combined, you know, we sort of dug fairly deep in terms of, you know, we wanted to kind of forge a motto, a rallying cry for our organization, you know, for everybody sort of to have the same common set of goals and values. And what we came up with was to serve and to excel. And the reason we put to excel after to serve is because, look, that's what we intended to do. Bring care to healthcare, focus on quality, and at the same time, you know, do it, improve lives, improve the industry, but at the same time be viable. And look, I'm happy to say that not only quality of care, but we are able to reach many people, provide free healthcare as well. You know, we are perhaps one of the most viable, profitable companies in the healthcare sector. And we do this while setting aside 10% of our beds totally free for poor patients. You know, we are able to reach, we are able to provide free healthcare from 10% of our beds, 25% of our OPDs are totally free. I think in pretty much we believe amongst the preferred hospitals in the markets that we operate in. We are able to do so because we are able to focus on quality, outcomes, and patient centricity. Word of mouth is very important. If your outcomes are not good, then typically in a place like Delhi and Bombay, you're not going to get too many repeat patients. 70 to 73% of our patient base is a repeat patient base, in fact. So I think, like I said, it's a prerequisite. There is no conflict. It's about sustainable growth. It's about sustainable profitability. What we wouldn't want to do is, shoot ourselves in the foot by looking at short-term gains, at the cost of long term.
Thank you so much. Great views. And that leads me to Mayank out here. Mayank, you've heard the views from both Abhay and Nachiket. I'm specifically talking about, I'd love to sort of address Nachiket's comments on pure indemnity insurance, right? Most developed countries have adopted a continuum of care insurance. The move from, what Nachiket refers to as owning the community, move to owning the community. Now, I know that you've been experimenting with some of this in India. So I would like you to talk about what are some of the barriers and what will it take for us to sort of actually have such holistic health insurance offerings in India?
Yeah, thanks, Harish. So firstly, I kind of completely agree with Nachiket and I'll give you one more perspective from an insurance side. The current model is not sustainable, right? So today, even on the current regulatory regime, any insurance, product is lifelong guaranteed once a customer gets into the contract. It's a customer's choice, whether they want to get out or not. So from as an insurer, once I select and underwrite a customer, then I have to kind of I have to provide them insurance for life. And as we all know, it's a very episodic, reactive kind of a model that we have in India, where the insurer, the payer, will actually pay when the actual event happens and has no idea whatsoever what really is happening in the life of the consumer as far as the health is concerned prior to that incident. Now, if as insurers we have to work in this model, the only way it can work is where I'm consistently acquiring fresh customers where who are probably slightly better health condition and have been underwritten more recently than the ones who have been with us for long, so that it's taking care of potential health condition kind of deterioration for the older pool of customers we have. Now that's not a sustainable model at all from a pure business economics perspective of a payer in India. No wonder you see today many of the payers are struggling with their economics of their health insurance business. And that's where we felt when we came in that there has to be a play where you start doing two things. One is you start kind of attracting consumers into insurance much ahead of time than normally when they think about it, right? Typically you start thinking about it when you are 35, 40 years of age and you have a family and you have children and you start thinking about it. But that's too late in my mind because you've actually, India has 65% population which is actually below 35 years age. You have to get them early. The payer model is finally of subsidy, right? I mean the younger and the healthier consumers subsidize the older and the senior citizens. That's one part of the problem. The other problem is that since we are covering only secondary and tertiary care expenditure after the event has happened, there's a large part of the healthcare spending which is not getting covered, which is the outpatient expenses. That's where you typically get the data around what is really happening in the life of the consumer, what is the health condition, what might lead to a risk condition which actually needs intervention much ahead of time so that the actual episode which leads to hospitalization can be deferred, and so on and so forth, right? So that's where we attempted in a small way to kind of say that one is to make the offering more exciting for the younger and healthier consumers by saying that you keep taking care of your health and we'll incentivize that behavior of yours. And second is that bring in this whole chronic care management with a few conditions we started saying that we'll cover that from day one, don't worry. And if you have those conditions, our whole ecosystem of kind of our own health specialists and partners will work with you to manage, let's say, a diabetes condition, right? Now that's in a way what in a more when it becomes very mature is the managed care model where you're kind of working with every customer of yours to kind of make sure that their health is managed in the way it should be, right? Because that makes sense for the payer, that makes sense for the consumer, and overall, if at a macro level, that's where we want to end up. I think there are a few issues that has to be managed. One, from a regulatory perspective, to bring in the whole outpatient coverage into the pool. The current pure insurance model will not work because outpatient is not, is by definition not 100% what you call insurance. Insurance is finally a game of probability, right? And the outpatient expenditure is not necessarily 100%, like that the pure insurance thing. So you have to bring in some element of what, in some of the other advanced countries, like from our partners from South Africa, which is a fairly advanced, I would say, an innovative market there. You have to bring in a health savings account concept, right? Where consumers use their own money at where they have discretion, they must be accountable for how that money is being spent. The moment there is an element of, insurance or, risk comes in, the payer comes in. And I think that's one, I think regulatory change that if that happens, clearly, outpatient, expenditure coverage can definitely increase. Then there are some tax issues because, the way today products are, you have 18% tax. Now, on a pure play fund, OPD expenditure fund product, you can't have an 18% GST. It completely kills the economics of that from a consumer value perspective. So there are a few things that have to happen at both allowing, some of the current regulatory regime to change a bit to allow this whole fund-based model for the discretionary part of the expenditure, some changes in the tax regime. And because, by the way, all payers are very keen to do that now because, even from a business perspective, it's a large amount of money in the healthcare expense. 60% of healthcare expenditure is that space, not covered completely. So I am completely in agreement with what I heard Nachiket say. And, hopefully if we all work together, we should be able to make some changes in the Indian model also.
Thank you so much, Mayank. And that's, again, like you actually preempted my second question. We possibly have a few minutes left. That's about all. And we have minutes for a quick fire second round possibly out here. I'd like to start off again with a question for Ms. Patel. Right, you've talked about some of the learnings and some of these exciting programs. Obviously, we don't have enough time for us to really learn about each of these programs in great detail, right? But can you just sort of highlight and what your experience in innovative financing and how could it be relevant for other stakeholders, whether it's the government or whether it's insurance companies or whether it's other provider stakeholders, and how could your experience translate to others?
Well, thank you so much for the question. And I think from our end, really, as we've learned from USAID at least, there's a lot of important values from our experiences, but also those around the table right now. I think that from our perspective, what we found is that whether we improve public financial management or look at conditional financing or even look at these various bonds that I mentioned, development impact, social impact, you name it. You even just heard about the blended financing facility that we're trying to introduce with partnership with somebody at the IP Global and the National Health Authority. All of these are just important ways in which we try. All we can do is be adaptive to the circumstances. And certainly right now, what we found is that we've got to do more. We've got to find more creative ways to meet and address the existing development challenges. There is no one size or silver bullet or magic bullet that fits all. And I think what we've certainly found is that especially when it comes to infrastructure and health, it continues to remain a priority. There's a great need for private capital from banks and financial institutions and a need to leverage. So from our perspective, at least, when we're able to take 1 to 200 investment, like for instance with IndusInd Bank through a $50 million loan payment or guarantee, it clearly makes a difference. So for us, at least, while there's different models out there, we've got key learnings from, Utkrisht or Mukti, and we've certainly been able to at least put financing to practice, at least to be able to improve quality. There's still a great need. There's a lot more to be done, especially with COVID, and certainly we do hope that when we consider how to crowd in private financing, that we're not also crowding out existing resources. There's got to be some way to have a blend of both. But these are some of our experiences, especially with pay for performance and also being able to complement the system and use existing, activities and be able to co-design and co-create.
Thank you so much, Dr. Patel. Now, heading to Nachiket. Nachiket, you've heard, and right through this morning, we've been hearing about evidence, right, and evidence-based medicine. And I understand that we are sort of at the very, very nascent when it comes to data collection. There is data, however, and it exists in silos. For example, you have claims data for the last 10 years. It exists in a with all the insurance companies. There is say governmental institutions pick up data. There is economic data of various orders, etc. Now, how do you envisage this data sharing? Because I would see that data sharing is going to be very, very important if we really want to bring some of these aspects of value-based care. And indeed, if you want to bring technology, larger technology plays into the area of healthcare. And how do you sort of actually harness this data? And how do you address concerns around privacy and patient confidentiality, etc., which currently seems to be the major reason which is touted for this data not being shared widely?
Yeah, no, I think you make a very important point. The good thing is that IIB is sitting on a lot of information. Currently, I don't know how electronically analyzable it is because a lot of information has come to them using more traditional mechanisms. I'm involved with an entity called the First Digital Health Foundation. We are working with both the National Health Authority and IRDAI to build standards for an automated health claims platform, so that you can get rapid settlement of claims across diverse providers, which of course is the benefit to the consumer. But the big benefit from a data analytics perspective is that now I have really robust, high quality electronic data that I can start to move forward. Clearly, one big impediment is the fact that our healthcare providers are not electronically enabled. Most hospitals, I would imagine 100%, but maybe there are exceptions. You're still carrying your big fat files around of X-rays and this, that, and the other. So you really don't have the ability to get that information. So while yes, privacy is an issue, but the world over, people have dealt with privacy concerns nicely. I don't think that necessarily should bar us. We need, a lot of work to happen. But I'm with you. This is quite an important part of what needs to be done.
Thanks, Nachiket. Now, we are almost out of time, but I'm going to sort of hand over to Abhay for a couple of questions, Abhay and Mayank for a couple of questions, both identical questions, actually. Right. Abhay, we talked about, in the morning session, we talked about trust, especially trust when you talk about public-private partnership, and it can only thrive if there is trust between both the government and the private players. A quick thing, what would you like to see change on the government and regulation side to really help and further this cause of public-private partnership?
Look, I wasn't a part of the morning session, but I'd like to get a important point in here that look, by the end of the day, the crux of the matter is that there is a trust deficit, and it's largely due to the fact that providers are seen to be profiteering rather than profiting. However, it's also a statement of facts that in India we are probably one of the cheapest healthcare providers in the world. Our doctor colleagues, nurses, and so on and so forth are, their take home is perhaps less than what their peer groups is globally. Hospital chains, by and large, operate at low double-digit EBITDA margins, and even the best of them have been operating at high single-digit ROCEs. Now, clearly, there is a need for creating healthcare infrastructure, more and more healthcare infrastructure. Less than 5%, as pointed out in the previous presentation, is provided by the corporate sector. And I think the COVID has thrown up the requirement. Not only our country, perhaps every city over here requires more and more healthcare infrastructure to be created. Now, the worst thing that we'll end up with is continuing with the trust deficit and bringing further regulations into play in order to tackle that. I think what we need to do is, in fact, I think regulation is one of the problems. We need to bridge this trust deficit by reducing cost of healthcare, because it's also a statement of facts that India is a poor country, and although healthcare is amongst the cheapest in the world in India, it is still out of reach of most of the people. The way to do this, in my mind, is in fact to reduce regulations. We are sitting on, each one of our hospitals has more than 100 licenses per annum that we have to get sort of renewed. We are still working with archaic regulations such as FDA, etc. I mean, even till date, if I have to store pharmaceuticals in multiple places in my hospital, I have to get a licensed pharmacist to be sitting over there and doing actually a chowkidar job. And you can't even have the same pharmacist in two places. You need a separate, exclusive pharmacist. If you're setting up hospitals for Ayushman Bharat, you're required to create parkings, because the building code required you to create parking. It's not as if poor people are coming. So look, I think whether it is creation of infrastructure, we can make it much more reasonable, and therefore, the cost of healthcare can come down, or reducing regulations which help, which kind of drives up costs of providing healthcare. To be able, if we're able to streamline some of these, if we're able to iron out some of these, we can bring down that cost. Some of the requirements of the healthcare sector, I mean, look, land has been a major issue, building codes, every state, every city has a different building code and so on. I think, bringing standardized norms, bringing sort of even platform, single window for something like this would help, and would help in creating infrastructure. This can be done through public-private partnerships. We have railways, we've got post offices, we've got enough public sector undertakings, ministries, and so on and so forth, who are sitting on land banks all across the country. Get into private-public partnerships, reduce regulations, bring single window sort of clearances, and make it a priority sector. I think all of these things will enable creation of assets, multiple benefits to the economy, including employment, and can also help in reducing cost of healthcare and ability to provide free healthcare to more people as well.
Thanks, Abhay. Great thoughts. And moving on, last to you, Mayank. Some final thoughts. You already talked about two, changes you'd like to see. You talked about a health savings account. You talked about some of the tax issues. What's foremost in your mind as to other things which you might want to see sort of vanish from the regulatory side, or really become significantly easier on the regulatory side to really provide a much more holistic insurance product? Mayank, I think, are you on mute? Yes.
Sorry, from an insurance regulatory perspective, I'm not sure, we need significant enhancements or, other than the one that I mentioned to you. I mean, I think the bigger challenge that we face today is because the coverage of insurance is so low, and therefore even the combined, buying power of the, the payer category and the ability to kind of work with the provider category. I think that conversation and the quality of that conversation is very, very poor, I must say. I mean, and therefore, to me, whether through a health, some kind of a regulatory framework or some other intervention, that process of conversation between payer and provider has to improve today. Some of that is happening because of the fact that we are into a pure indemnity kind of an environment, and that in the hospitalization space, and therefore it's too small a coverage. And some is because even there the coverage is so low that our ability to go and talk is really restricted. But I think some of that is also because of the health regulatory framework today. I mean, it's shocking when you get into the health insurance, the fragmented environment that you suddenly deal with, right? I mean, 15,000, 18,000, 20,000 hospitals across the country. And of course, there are large chains which are where you know what you're doing, but the smaller ones where you struggle to deal with them, you find a fraud, you take care of them, and suddenly some other by some other name, another hospital springs up there in the same place, and so on. It's a very difficult operating environment to deal, to make, provide that experience to the customer, and also deal with the economics of the business, which will finally make it sustainable. So I think those are areas that we have to tackle. There are multiple kind of angles from which that will have to be addressed. But if you really want to make it, meaningful, then, all of those will have to be looked at for sure.
Thanks, Mayank, and thanks everyone for this. It's been a scintillating discussion, and I really think it's been fabulous. I'm not even going to attempt to sort of summarize this discussion because we are well out of time out here. But Nachiket, we'd love to have your slides if you're okay with it for public consumption. And I know that each one of you has so much to offer, and hopefully we will have several more discussions on each of these fronts which you've raised out here. Thanks, NatHealth. Thanks for this opportunity, and Aishwarya, on to you now.
Thank you very much. Thank you very much to the eminent panelists, and thank you, Mr. Natarajan, for that wonderful steering of the session.